Good evening, everybody.
I think it's because the computer is nearby.
Hi.
We need to be a bit further away from each other. Can I try it again? See how it works?
Good evening. Sorry, we're just waiting for the echo to go away. Just one moment, please. Right, I'm going to begin this evening. First of all, I'd like to thank the Adelaide PHN for funding this very important training session. The GP Management of Headaches is brought to you by Dr. Zhang. I'd just like to run through some housekeeping. Please keep your microphones on mute during the presentation. Host and presenters will unmute everybody when input is required. Could you also submit your questions through the chat feature, and we'll be able to take the questions to Dr. Song on your behalf. Please complete the evaluation forms at the end of the session. These evaluation forms are really important for both SAPMEA and Dr. Zong and the Adelaide PHN. It's important for us to know exactly what kind of learning you require and how you measure the training session that you're attending. There will be a certificate of attendance sent out electronically following tonight's presentation. I'd like to acknowledge the Aboriginal and Torres Strait Islander people as the traditional owners of this country. We pay tribute to their physical and spiritual connection to land, water and community, ensuring now, as it has been through time, we pay respects to them, their culture, elders past, present and emerging. I'd like to introduce Dr. Zong. Dr. Zong was awarded a medical degree by Flinders University in 2010, graduating with honours. After completing his internship at Flinders Medical Centre, he underwent physician training at Royal Adelaide Hospital, with advanced training in neurology at the Queen Elizabeth and Royal Adelaide Hospitals, including a movement disorder fellowship under Professor Thompson, Professor Thomas Kemba and Shav Pravzifam. He has experience in advanced therapies for Parkinson's disease, including deep brain stimulation. His experience, he's been involved in numerous clinical trials for memory disorder and strokes, as well as movement disorders. Dr. Zhang is currently a consultant neurologist at Flinders Medical Centre and continues to be involved in clinical research at Royal Adelaide Hospital. He has a broad interest including movement disorders, epilepsy, headaches, functional neurology disorders, stroke, behavioural neurology, multiple sclerosis, as well as general internal medicine and preventative health. I'd like to hand over now to Dr. Zong. Thank you very much, Dr. Zong.
Hello. Hi. Okay. Can you hear me? Okay. The slides, are they going to come up? How do I can see myself, but I don't have the slides.
Just 1 moment.
There we go. Okay, perfect. Okay, so thanks for signing in, everyone. So just a few disclosures. I have received travel grants and educational support from a number of companies, some of which manufacture products that potentially we'll discuss today. In particular, so AbbVie, which now owns Allergan, which they produce Botox, as people might know. And also Teva, Novartis, and Lilly produce 3 of the monoclonal antibodies targeting CGRP, and they're all quite pricey. So just keep that in mind when I sort of talk about their use. I might be clouded by my hospitality, like free coffees, etc. I also have discuss a few off-label uses of medications that is not TGA approved, strictly speaking, for treatment of headache disorders such as valproate, amitriptyline, etc. You can have a look. Okay, so moving on. This is a rough schedule that we'll hopefully try to stick to for your reference. So without further ado, taking a history, I think is part of the cornerstone of formulating a headache diagnosis. So often what you want to know when a patient comes in complaining of headache, you want to know when did it start exactly, what were they doing when it started, whereabouts in the head or face or neck do they get it, and how does it come on? Is the headache there when they wake up in the morning? And if it is, how does it change as the day progresses? Does it get bad? How long does it take to get to maximal intensity? Or does it come on sometime during the day? And if so, where does it come on, and then how does it progress? Does it take seconds, minutes, or hours to get its maximum intensity? And does anything bring the headaches on that they've noticed? Whether they're the period, whether work stress, fragrances or perfumes or alcohol, different type of food, lack of sleep, too much sleep, bright lights, etc. And you want to know how often the attacks are, and then the quality of the pain that they get. How do they describe it? Because that can point to a certain headache disorder or a different one. For instance, a throbbing pain or pulsing pain often points towards a migraine, whereas a dull, featureless, continuous ache or pain, more attention type headache. And then you want to ask, where does the pain go? And how long does it last for? Because if you look at the diagnostic criteria, there's certain minimum durations of time before you can call some, and indeed maximum duration of time before you can call certain headaches one or the other. Keeping that in mind, the headaches don't read the textbooks sometimes, so you kind of have to guess. But as a general rule, I think if you're looking at this from a usual general practice perspective, and indeed even from a sort of specialist neurological practice perspective, we do try to be precise about the headache subtype. You want to ask any associated symptoms that come with the headache. Do they get nausea? Do they get vomiting? Do they only get nausea but no vomit? Are there any visual symptoms that precede the headache or are concurrent with it? Any focal neurological symptoms? So are they weak or numb on one side of the body or the other, versus they just generally feel weak? Are there any autonomic symptoms? Does the eye puff up or swell or droop or tear up, or is red or injected? Do the sinuses feel blocked ipsilateral to the headache side? Do they have rhinorrhea or feel their nose gets blocked? Do they have oral fullness, a sensation of ear being blocked? And do they have this cognitive slowing, or do they feel hungover or flat? How long does that last for? Often people with migraine can get the so-called migraine hangover the day before the migraine, or it persists the day after the pain has resolved. And any factors that aggravate the headache. All right. So, does walking around make the headache better or worse? Are they restless with the headache? And do they have photophobia or phonophobia or osmophobia? And does anything does the headache change with posture? If they're bending forward or they're straining or they're coughing, does that make the headache worse? All right, so there's all the sort of things that we want to get through. And so once you've done that, you should ask them what they've tried. Because often people would have bought over-the-counter paracetamol or ibuprofen, or they've seen some other practitioner and then they've been prescribed some sort of treatment. When do they take it? This is quite an important question because a migraine treatment, for example, is much more effective taken as soon as the headache begins. If you leave it a bit too long, then often it doesn't work or doesn't work as well. And patients not infrequently will say, well, trying to avoid drugs, so I sort of leave it until the headache is very bad, then I take it, and well, it didn't really work. And then so sometimes I need a bit of education. Then you also want to know, well, how much do they take? I mean, do they take one ibuprofen and then, didn't work, the next time try one paracetamol? Bearing in mind that these are over-the-counter drugs, they're often very conservative. I mean, if they're going to buy drugs from Woolies or Coles, they'll just say, well, take the safest dose you can. And, we know that we can actually give people 600 or 800 milligrams of ibuprofen at once, for example. And what do they do? Do they take it, by itself, or do they combine an NSAID with paracetamol? And with a triptan pep and with a dopamine blocker, or do they just take one or the other here or there? How often do they have it? Because people can give themselves medication overuse headache if they overuse paracetamol or triptans, for instance. And if they do have the medication, how quickly does it work? I mean, is this a natural history of headache anyway? They have a headache, they take the medication, and then 3 hours later, the headache goes away. Is that because the headache would have gone away anyway by 3 hours? Or they say, oh, after I take it about half an hour, the headache starts to ease off. They say, well, okay, that's probably the medication working. And then, if they say, oh, I take the tablet and within 5 minutes or 3 minutes, the headache's better, then it's probably psychosomatic, sort of a placebo effect. Then once you talk about acute treatment, then there's a preventative treatment, and that's medication that people take every day, all the time, whether they have headache or not. And the intention of that, of course, is to reduce the frequency and severity of the headache. So you want to know what preventatives they tried, what dose they got up to, how long did they take it at that dose, and why did they stop taking it? Was it because it didn't work? And if it didn't work, is it because they didn't get high enough dose or didn't give it long enough? Or did they stop it because they had an adverse reaction to it? In which case, you need to find out the nature of the reaction to decide whether you want to challenge them with it again or not. Once you've done all that, then you try and work out what other past history they have. And perhaps this is, maybe it's obvious to you if you're a usual GP, but if you've never seen the patient before, then it's something you'd like to know. And you want to know their family history, because there's certain headache disorders are somewhat more heritable than others. Okay, so once you've done all of that, and of course I neglected to mention all the psychosocial things, so smoking, alcohol, illicit drug use are all potentially relevant for secondary headache causes, for instance, and their social situation, I suppose, considering that stress probably worsens your headaches. Once you've done all that, it's time to move on to the physical examination. Really very important to do a detailed neurological examination, check the cranial nerves, go from 1 through to 12, don't skip anything. the more you do it, the quicker it gets. You ask them how's their smell, you check their visual fields, you check if there's any focal scotoma by covering one eye and then the other and asking if any part of your face missing or blurry. Then you perform fundoscopy, and I think that's one of the things that if you don't do it often, it gets difficult to do. But if you practice it frequently, then it gets quite easy. And sometimes you'll pick up other unexpected things. You might diagnose a patient's poorly treated hypertension, or you might realize they're diabetic just from a fundoscopy. Maybe a little challenging with a sort of regular ophthalmoscope, but if you practice, it's not too bad. You can, of course, outsource this to an optometrist if you wish. Then, so you go from 1 through to 12 systematically because you're trying to look for any other cranial nerve palsies. And then when you're examining the fifth cranial nerve, you might want to assess for pressure or tender points around the scalp as well, since you're touching their face anyway. So you're trying to ensure that they have no cranial neuropathy. Once you've done that, then you do the upper limb, which is the usual sort of tone, power, reflexive coordination, sensation. You can, if you're not expecting to find anything abnormal, the power of exam is very brief. You can do shoulder abduction power, finger extension power, so you know proximal and distal are normal, and that's all you need. So you go through the thing, check if you've got any cerebellar signs, for example, and coordination and sensation. And then the lower limb, usually I do a quite truncated exam in my rooms. I sort of watch them walk, make sure they can squat down and stand straight up again, so that way you know their power is normal. And you can probably omit checking reflexes and doing the plantars unless you find something abnormal elsewhere. All right, so essentially you're trying to exclude any localizing neurology, because if people have localizing neurology, then it's almost mandated that they get some sort of cross-sectional imaging. If they have no abnormal neurology and the headache history is classic, then you can quite confidently diagnose someone with a primary headache disorder without needing to do an MRI on them. Okay, so that's the physical exam part. Of course, this is predicated on you being confident to know what is normal and what's abnormal. And the only way you can kind of get good at that is to examine the patient frequently, so that you're confident that something abnormal is really abnormal. All right. Okay, so once you've done all that, and usually, I mean, the assumption is that they have a normal exam. So most people present to medical practitioners with migraine. Most people with tension type headache tend to self-medicate, especially if it's sort of only infrequent. So the majority of patients that you see coming to you complaining of headache are people with migraine. Now, there's this assumption that people with migraine need to have aura. That's not actually true, because only 1 in 5 migraineurs have aura. The majority of migraineurs do not have aura. So this is the International Classification for Headache Disorders, 3rd edition criteria for migraine without aura. And they need to have at least 5 attacks, criteria B through D, should last for 4 to 72 hours, which is why the duration is important. Having said that, people can have headaches that last longer than that. Maybe they have a second attack, but anyway, this is the criteria. They need to make the cutoff some way. And headache quality should have at least 2 of the following characteristics. The pulsating or throbbing quality, I find, is probably one of the most helpful. Moderate to severe pain intensity, so it should be at least 4 out of 10 pain or worse. That's, for my mind, that's moderate. The 1 to 3 is mild. It's a bit vague, but that's how I judge. Headaches often worse if they move about. The unilateral location is nice to have, but you don't always, it's not always the case. And when they have the headache, they should either feel nauseated or they should vomit or both, and they have phonophobia or osmophobia or photophobia. And then the D is always one of those catch-all terms that you always find with all these diagnostic criteria, so-called not better accounted for by another diagnosis, which is you'll find that in psychiatry and all sorts of other diagnostic criteria. Okay, so now moving to migraine with aura. 20% of migraineurs have aura. So they have one or more of the following aura symptoms. They have visual, which is often either scintillating scotoma, or they have fortification phenomenon, so-called, because they look like battlements in their vision, or the kaleidoscope pattern, fractal patterns, heat haze, etc. Or they can get a sensory aura, tingling in one arm or leg or in the face. They can have dysphasia, so speech finding difficulties or language problems, or they have weakness in one arm or leg, not a generalized weakness all over. That's not counted in aura. Or they can have brainstem aura, which is nausea, or vertigo, true vertigo, i.e. a sensation of the world spinning around with your eyes open, and then it improved or diminishes or abolished with eyes closed. Or they can have altered sensorium, or decreased conscious state, or they can have a sense of disequilibrium, feeling unsteady on your feet, which they might complain to you as dizziness. But it is important to tease out whether this is true vertigo or whether there's a disequilibrium or pre-syncopal sensation. Or they can have a retinal aura, so it's called retinal migraine, if you're blind, or they get blind spots. So anyway, I won't sort of label the point, but there are diagnostic criteria, and it should, the aura should spread over time because of the so-called cortical spreading depression, where neurons become progressively hyperpolarized and less likely to activate, thus causing loss of function. All right. Okay. So those are the main common migraines that you encounter: migraine without aura, and then number two is migraine with aura. But they're always rare conditions. So migraine with brainstem aura, they have two or more related brainstem aura. They have dysarthria or tinnitus, diplopia, etc., or clumsiness, so ataxia, and they may have visual aura, etc. This is something to be somewhat cautious about, because of course having migraine does actually put you at increased risk of stroke. So one cannot say, oh, this person is non-migrainer with brainstem aura, therefore they are suddenly abruptly ataxic, or it's definitely one of the usual migraine attacks. Normally migraine attacks should be quite stereotyped. So if they have the aura, it should always be the same kind of aura with each attack. If their aura is different, then there's every possibility that this is that they're having a stroke, for example, and they should be treated seriously, because time is critical when someone's got a stroke. So one must be careful not to play down patients' aura, even if they are non-migrainer with aura. If it's different, then you should probably send them, call triple and get them to a hospital. So that's migraine and brainstem aura. There is vestibular migraine, which is distinct from brainstem aura because they only have vertigo. They have no other brainstem type aura, and you need to try and be able to distinguish from Meniere's disease, presumably because in Meniere's disease they also have hearing loss, they also have tinnitus, and it is progressive and more long-standing, whereas vestibular migraine is episodic. Retinal migraine just involves the eye. They can get hemiplegic migraine, quite unusual. It's a big stroke mimic. And unless you know that they definitely have hemiplegic migraine and their presentation is very stereotyped for the usual hemiplegic migraine, that's the sort of people that you sort of send to ED because you think they possibly are having a stroke. And then you can let the ED doctors and presumably the neurology or stroke team from the hospital deal with it and make sure that this is not actually a stroke. And finally, you can get this phenomenon called migraine aura without headache, or late life migraine accompaniment, where people essentially get neurological aura without much, if any, headache. But again, this is rare, and it's just something to bear in mind that it could be a possibility. All right, so I'll move on to talk about medication overuse headache, because this is iatrogenic. This is something that's caused by us giving the medication. So this is the formal ICHD-3 criteria that I've sort of copied and pasted from UpToDate. But here it says, a headache occurring 15 or more days. But I think it's a little bit artificial. I mean, if someone's got a headache sort of 14 or more days or 10 or more days a month, because they're using paracetamol every day, I think that you probably still have a contribution from medication overuse headache. But anyway, practically speaking, even though it says on the formal criteria that NSAIDs are implicated, there have been a number of observational studies that show that that's not actually true. And in fact, your odds ratio of having medication overuse headache if you take regular aspirin or ibuprofen or naproxen, for example, is actually lower. You're less likely to have medication overuse headache if you use an NSAID. But for my purposes, I often tell people to have no more than 2 days a week. That way you are unlikely ever to hit someone with 10 or more days a month to give them this problem. All right. And the next headache disorder we'll talk about is tension type headache, probably because that's probably the most common headache subtype in the general population. Not necessarily the one that they seek medical attention for, because they're usually not that bad. But here's the formal diagnostic criteria, and that's probably the two main differentials you get when someone complains of a headache. These are the two things that you have to think about. So tension type headache usually is bilateral and a pressure sensation of mild to moderate intensity. Usually doesn't last that long, and actually it says minutes to days, but typically they're 1 or 2 hours. And then they talk about the frequency. All right, I'll just let you read the rest without sort of reading it out to you. Now, I'll take another primary headache disorder, cluster headache. And why do I bring this up? Because it is a very, very intense headache. And sometimes they call it sort of a suicide headache, because people have been driven to suicide because of how severe these headaches are. They are not migraines. You might see people throw about this term called cluster migraine, which is a nonsense term. There's no such thing. So cluster headache, this is the formal diagnosis. They are severe. They are sort of at least 7, if not 8 out of 10, up to 10 out of 10 pain. It's unilateral. So it's usually around the eye or just above the eye in the supraorbital area or in the temple. And the pain lasts for 15 to 18 minutes if you don't treat it. They can wax and wane a little bit during the actual attack. And sometimes they can be a bit longer and a bit shorter. So you need to have either or both of at least one of the following autonomic symptoms. So cluster headache falls under the broader umbrella term of a so-called trigeminal autonomic cephalalgia. I will touch on the others down the track, mainly because you'll feel very clever if you diagnose one, and some of them are very treatable. But cluster headache, I think, is one not to miss, because they are very severe indeed, and they're one of the few headaches that we triage as category 1 when you send a referral into the public hospital. But it's eminently treatable in primary care because there's nothing magical about the treatment. So I'll labor the point a little bit. So you wonder about autonomic symptom. The eye should get red, or they should tear, or both. The ipsilateral nose. So let's say someone always gets cluster headaches over their right eye. Their right eye should tear up, or their nose on the right nostril should block up during the headache. So people might say, well, my sinus is always blocked anyway because I got allergy. Well, okay, but is it worse when you have the headache? And oh yeah, it is. So yes, that counts. Their eyelid gets puffy. They can have sweating or flushing in the same side, the forehead or the face, and they can have autonomic features. The pupil gets sort of dilated or droopy, as mentioned. And this is a helpful distinguisher from migraine. They have a sense of restlessness or agitation. They are rested. They pace about. Not necessarily because it makes the headache feel better, but it might do. But they might just feel, well, I feel terrible, but I just can't sit still. And this is quite a helpful contrast to migraine. And migraine, the people say, well, I just like to lie still and do nothing. You can have both. You can have cluster headache and migraine coexisting, but I think it's important and helpful to try and distinguish between the two. Now, the frequency is quite variable. They can get one every other day, and they can get multiple attacks per day during each individual bout of attack, which they can get for a few months at a time. So it is important to think about. And like migraine, like tension type headache, we distinguish them between episodic versus chronic. And the episodic is more common. They can have episodes or clusters during which time they get a lot of attacks, and this can be 7 days up to a year, and then they will have no attacks for several months. So by this definition, 3 months or more, and people can say, I don't have any. I have attacks once every 3 or 4 years, but it can become more frequent as time goes on, unfortunately. So if chronic, it's sort of the remission. Remission is for a shorter period of time. Sorry, let me just bring this up. There's a question: could a tension type headache persist for weeks during the day but not at night, or not disturbing sleep? Yes, is the answer. All right. So most headaches don't stop people from sleeping, and in fact, people usually feel better after they've gone to sleep. Most primary headache disorders. Does that answer your question? I'll take, well, you can follow up question if necessary. Okay, so there's a few cases. They are sort of based on real patients, but so they're semi-anonymized, because in a town like Adelaide, you can kind of work out who people are. So 30, this is a fairly typical patient that I might see. 30-year-olds that headache since the age of 15. They can start at either temple. And it takes about, from onset to its maximum intensity, it's about an hour. It sort of starts out not too bad, and then it builds up, spreads from the temple up to the vertex. Pulsing, throbbing quality, quite severe, 7 to 8 out of 10. Just wants to lie still, has photophobia, phonophobia, and osmophobia. Doesn't want to see anything, loud noises make it worse, and smells make it worse. So patients often get confused about this. The osmophobia is not whether the smell triggers the headache or not, but it's whether when you have the headache, does the smell make it worse? That's the definition of osmophobia. She's often nauseated with these attacks, but doesn't usually vomit, only rarely. And she does get some sinus pain, but she says, I tried sinus rinses with saline, etc. It hasn't really helped. And the ENT surgeon says they're not going to operate. And the eye gets red. She's got no other autonomic symptoms to go with it, and there's no focal neurological symptoms to accompany them. They come on the day before the period quite reliably, but she gets at least one other attack, up to 3 other attacks, so anything from once every 2 weeks to once a week, she'll get an attack as well. Some alcohol triggers it, maybe some sorts of dark colored spirits and some sorts of red wine will trigger it. Staring at the computer will trigger it, as well as a bad day at work or bad day at home, getting dehydrated, having lack of sleep. All triggers that the patient's identified. The headaches will last between 6 hours to all day. She goes to sleep, and the next day doesn't have any more headache, but still feels washed out. Able to go to work, but just barely, and doesn't function at peak capacity. And the day after that, she's back to normal. So they seem to be a bit more frequent now. They're sort of more in the sort of 3 to 4 attacks a month, which is why they presented to come and see you. And previously, she's noted that if she takes 2 ibuprofen or 2 paracetamol during her headaches, it is somewhat helpful, especially if she takes it early enough. Okay, so she has intermittent asthma only when she has a cold, but otherwise not really. And she's got mild she's mildly overweight. The BMI is about 26 or so. She's on the pill, and when she remembers, she takes vitamin D, but it's not very reliable with that. In terms of family history, her mother has type 2 diabetes and migraine. Her father has hypertension. One sibling has migraine, and there's no other family history of note. She has no children at present, but may consider having children in the next 5 years or so. She's never smoked, drinks alcohol rarely, well, not that rarely, I suppose, but she has maybe a glass or two of wine once or twice a month, has never used illicit drugs, and works as a school teacher living at home with her partner. You've examined her, and examined is normal. So we're going to move to a quiz just to keep everyone awake and on their toes. This is not a trick question. We can bring up a poll potentially if my colleagues here can. I'm sure they can work it out, but I'm not that au fait with Zoom. But anyway, I don't know. Here we go. Here's the poll, and not a trick answer. Not a trick question, I should say. What does the patient have? Chronic migraine with aura, without aura, episodic migraine, with aura, episodic migraine, without aura, or medication of use headache. And having decided what they have, what would you suggest? Should you have acute treatment only, acute or preventative one? And what sort of preventative might you consider? Should you suggest some lifestyle measures, or should you suggest some supplements that are migraine preventative? Now, for the first question, there is a correct answer. The second question doesn't really have a correct answer. It's sort of there for people to come up with their answers. So if everyone would like to put the answers in, and then we can see what everyone does, what the results are, and we can then sort of discuss it a little bit and see what people have. All right, are you ready with the results? Or maybe not. Oops, resume slideshow. Okay. So, all right, so, good. Yes, so everybody got the answer. Well, I don't know. Then people click the wrong button, I presume, for the first one. But yes, the majority is correct. She does have episodic migraine without aura. So the definition of chronicity for migraine is that people must have 15 or more headache days a month, of which 8 or more are migraine days. So that is the clinical trial and the ICHD3 definition of chronic. All right. Now, what treatment would you suggest? That's a sort of good split. I mean, you can probably answer all of the above. I mean, lifestyle measures are possibly helpful. You want to think about whether, she's mildly overweight. Does she have sleep apnea? Does it need to be treated? Assess how much caffeine she has. Does she have a bit of medication of use headache from having too much caffeine, for example? If you can, some people don't like medications for various reasons, and but they're happy to have things like riboflavin, coenzyme Q10, magnesium, alpha-lipoic acid, L-carnitine, all of which have variable degrees of evidence in terms of being a migraine preventative. So whether you go on just acute treatment or just preventive treatment, sort of it depends on the patient's preference and how debilitating the headaches are. For what it's worth, I personally will offer both. I think they are quite frequent enough to have both preventative and acute. But if someone really doesn't want to take a preventive treatment, it's not unreasonable to try and optimize the acute treatment first, because if as soon as the headache starts, it takes a high dose of an NSAID together with paracetamol, together with dopamine blocker, and the triptan, and it works, then you're taking medications 4 days a month rather than 30 days a month, which might be preferable. Okay. So another case. Sorry, I'll just go into the previous slide. Oops. Oh yeah, here we go. So this patient is 45-year-old male. He started about age of 18. Initially, would get 1 or 2 attacks per year, and then they went away by the age of 25. And he had no problems, but then somewhat inexplicably, they started again 5 years ago. And they're becoming slowly more frequent with time. Initially, would get 1 attack every 2 or 3 months. So, 4 to 6 times a year. And then it's gradually gotten more frequent, such that now the patient gets headaches nearly every day. Might get 1 day, a fortnight, or 1 day a month having no headaches. Back in the bad old days when people had this drug called Digesic, which is a combination dextropropoxyphene, paracetamol, it's not available on the market anymore, thankfully. He found it very helpful. But then they took it off the market. And now he takes paracetamol codeine combination or ibuprofen codeine combination, which he also finds helpful, but is not as good as the good old Digesic. But over time, this has become less and less effective. What it still does is that it can take the edge off that pain, and he says, well, it lets me get to work and look after the kids. The headache itself is described as throbbing in quality. He will lie still in a dark room if he can, i.e. does not have to attend to his children. It often, but not invariably, preceded by flashing light in the periphery of the vision that again gets larger over 15 minutes, then it goes away, and then the headache starts and gets worse progressively over 30 minutes. And that this throbbing pain then lasts all day until he goes to sleep. Doesn't get droopy eyes, blocked sinuses, blocked ear, all the rest of it. And next morning, he wakes up and the pressure sensation is still there, but the throbbing has gone away. And now he has throbbing attacks about twice a week, but most of the day, as mentioned, he has dull headaches. And as previously I said, he only gets 1 clear day with no pain whatsoever, a fortnight to a month if he's lucky. All right. So the other past history, he has depression and anxiety, which is mild to moderate in severity, currently reasonably well controlled. He's got high blood pressure. He's a bit overweight. He might have OSA, not sure. He's been told before that he snores. But he does wake up feeling pretty crap. He's unrefreshing sleep, even though he slept for 10 or 12 hours. In terms of medications, he's on escitalopram, 10 milligrams, Mane, Perindopril, 10 milligrams Nocte, as we should all be on in light of a recent prospective trial showing Nocte dosing of antihypertensives are better. Then he will take either paracetamol or ibuprofen when the headaches come, which is nearly every day. And he'll alternate, because he has this misapprehension that if you take them together, they are too strong or they will stuff up your liver or kidney or both. And if he does get a throbbing headache, he will then alternate with either paracetamol codeine combination or ibuprofen codeine combination, which is about twice a week he uses this. He's a smoker, ambivalent about quitting. There's 1 to 2 full-strength beers, so 1.5 to 3 standard drinks a day, and used to use cannabis, but has had nothing for the last 10 years and has not used anything else. He works as office manager and lives at home with a child. He's a single parent. He's estranged from his family, so doesn't really know their past history. And he's moderately overweight. The BMI in the order of 29 or so, not quite obese yet. But otherwise, he's got no other. On examination, he's moderately overweight, but otherwise, he's got no other focal abnormalities. So I'd like you to have a think about what significant issues one ought to consider in a patient like this. What are the things that we should try and address to help improve his symptoms and his overall health? All right, so Another sort of poll question here. What management issues will we need to consider addressing? I think it's pretty uncontroversial to say that this patient has medication overuse, because he probably uses 15 days a month, say, of paracetamol, probably more, and opioids are notorious for causing medication overuse. Codeine is a really, really, really bad drug to have for headache. In animal models, for example, a single dose of codeine increases mu opioid receptor in the brain and makes animals prone to get a condition called central pain sensitization, and also makes experimental models of migraine more resistant to triptan treatment. So I guess excuse me. So he has medication overuse. He has chronic migraine with aura. I think that's pretty straightforward. Yeah, he's got 2 headache days a week, 2 throbbing headache days a week, I should say. So he has 8 at least headache days a month, of which are migraine type, and he has headaches most days. So you have about 28, 30 days a month of headache days, of which 8 or more are migraine days. One ought to be mindful that he's on citalopram, so that does constrain our ability to use certain migraine preventatives, because you wouldn't want to give. You can, but you need to be cautious about giving something like amitriptyline to someone who's already on SSRI because of risk of serotonin syndrome. And whether you can take the citalopram off or not and manage their anxiety, depression. So someone suggested propranolol and amitriptyline, both of which, okay, I mean, the guy's a smoker, so propranolol could cause bronchoconstriction potentially. It's also diabetogenic, so all the beta blockers, I suppose. You could consider a different beta blocker. Metoprolol is more beta-1 selective, that's likely to cause airway bronchoconstriction. Atenolol, similarly, is also more selective, but they both can cause diabetes, can limit exercise tolerance, and amitriptyline, as I think Jackie said, okay, so Jackie said, don't stop the antidepressant, well controlled, low dose, and they're not going to cause a problem, which is probably true. As long as you warn the patient sufficiently, that's true. So if we were going to start him on amitriptyline because, say, their sleep is not that great, and more problems stopping antidepressant, well, potentially. So I suppose that all depends on how well controlled their mood is, and for how long have they been well controlled on this drug, and what happened in the past when they ever tried to stop it. I mean, I suppose if someone's had a bad relapse and wound up in a heap when we stopped their antidepressant back in the past, then yes, probably don't stop it. But if they've been really well controlled for 5 or 10 years, then maybe there's an argument that we could try and wean it. But you're right. I mean, I take the point, not always straightforward. So I don't, and you know the patient better than me. I mean, presuming that this is a new patient, then all bets are off, I suppose. But you will try to put the antidepressant away from having them altogether. The sleep issues, I mean, this person might have sleep disordered breathing. They're not quite obese, I suppose. Maybe I should have made the patient obese. Then people might think about hypercapnia as a cause of early morning headaches. But it is worth keeping in mind. People often have poor sleep hygiene, and if they improve their sleep, often their headaches get better. It's quite apart from everything else. The carbon dioxide from his smoking, he might also increase the CO2 levels, so that's another thing to consider. All right, and he did have hypertension. He's already on perindopril, so maybe you could think about switching. So Dr. Yeo has made the point that check with the person treating the brain. Absolutely, that's very important. But Dr. Yeo made the point that we should always check with all the other practitioners. And there's some argument that perhaps we could consider switching the perindopril to candesartan, because there's some moderate evidence to suggest that candesartan can be effective as a migraine therapy for some patients. Or lisinopril, if you want to be very purist and for whatever reason really like ACE inhibitors because they have a mortality benefit compared to ARBs, which is true in some observational studies, then switch them to lisinopril at night time instead of the perindopril, which doesn't really have convincing evidence that it's that helpful for migraine. But that's a minor point. But all right, so let's move on. It's sort of nice to see people have given spur some thought, and that's basically what we're after. And we're going to move to our last case. So this is another 45-year-old man. Sorry, I know the headaches are generally somewhat more prevalent in women, except for cluster headache, which are more prevalent in men. But anyway, this is a 45-year-old man, and he has headaches beginning at the age of 30. They are extremely severe, and he's very restless. He's pacing, he can't get comfortable, and he describes it as like an ice pick hacking behind the eye. It goes for an hour, and he gets an hour, then it goes off, but then you have up to 3 attacks within the day, usually at the same times of the day, actually. And most attacks are on the left, 9 out of 10, and rarely on the right, 1 out of 10. But within each individual attack, it's always on the one side. On the side that the headache starts, his face is flushed, his eye is droopy, he's tearing up, the ear feels full, and he's runny nose. And when the attacks come on, he'll get them every day for 3 to 4 months, and then they will peter out, and then he might be fine for 2 or 3 years. Usually in the autumn. Why? Don't know, but that's when they come, and when the weather changes, he says. Otherwise, he's well. He's got no significant family history of note. He's got 12-pack year smoking history. Drinks 1 to 2 measures of spirits 3 to 4 times a week, and denies illicit drug use. He's a computer programmer, lives at home with his spouse and children. And examination in between attacks is normal. All right, so quiz time. What does he have? Does he have paroxysmal hemicrania? And this is slightly unfair because I haven't talked about some of these other conditions yet. I'll sort of mention them in passing down the track. But anyhow, it could be paroxysmal hemicrania, cluster headache, episodic migraine with prominent autonomic features. Does he have primary stabbing headache, or does he have SUNA, which is an acronym for short-acting unilateral neuralgiform headaches with autonomic features? The other one you might have come across is SUNCT, S-U-N-C-T, which stands for short-acting unilateral neuralgiform headache with contralateral tearing. So what of these headache disorders does he have? What sort of acute treatment should you give? And what sort of preventative should you give? Now, this is a terrible, this is an exam question I would fail as an exam giver, because when you set exam questions, you never, in general, you try not to predicate everything on the correct answer. You should assess each individual question on its own merit. The problem with this exam question, if you don't know the first answer, you get the first answer wrong, you get everything wrong. But this is not an exam, this is sort of a learning exercise. So I think, it is pretty textbook example, I think, of cluster headache. Acute treatment, you give them high flow oxygen, you will rebreather mask, or you can try and sort of ask the respiratory doctor in your local hospital department to approve home oxygen. Sorry, you do non-rebreather mask, I should say. It's as high a flow oxygen as you can go, 12 to 15 liters, the higher the better. And you should use it for at least 15 minutes. Even if the headache goes away after 8 minutes, they should still continue for 15 minutes. Otherwise, they run the risk of medication, of rebound. It's akin to a rebound medication-induced headache if you don't give the oxygen for long enough. You give them injected sumatriptan if you can get hold of it, but it is expensive. It's over $100 per injection. It's not currently available in Australia anyway. So if you can persuade your hospital pharmacy to pay for it, which probably applies more for people like myself, but you can give them inhaled sumatriptan, which should be put into the contralateral nostril from where they have their symptoms. So for this chap who's got left-sided pain most of the time, it should usually go into the right nostril. And on a rare occasion, he gets a right-sided pain, should go into the left nostril. Why? It probably is because they have congestion, blood congestion in the ipsilateral, in the affected nostril. So it doesn't get absorbed very well. There's a venous congestion or stasis in the sumatriptan doesn't get absorbed if you put it into the ipsilateral nostril. And they can be given steroids. Back in the day, this was a controversial question, whether steroids are helpful or not. There's a lot of anecdote back in the day that yes, it was helpful, but we all know the anecdote is not that great evidence unless you have no choice. But there's been a recent abstract published of a double-blind controlled trial comparing high-dose steroids at onset of cluster compared to verapamil onset with cluster, which is a reasonable practice to try and do. And the high-dose steroid group 1, is about 100 patients, and the high-dose steroid group did better with no significant adverse effects. Some of the other things that you can do if you don't want to give people prednisone, or back before we could give prednisone with confidence, we do greater occipital nerve blocks into the ipsilateral side with a local anesthetic and methylprednisolone mixture. So in terms of preventative treatment, lamotrigine is used to treat as a preventative for SUNA or SUNCT. It's also quite good for migraine aura, not so much for the headache, but it can be very helpful for aura. Indomethacin is a very good treatment for paroxysmal hemicrania or hemicrania continua. Now, this patient probably doesn't have it because it switches sides and it also lasts a bit too long, but that's something to keep in mind. Verapamil is the correct answer, also helpful for migraine. Melatonin can be used for primary stabbing headache. And pregabalin I put there because there is some conflicting evidence where it's helpful for tension type headache or migraine. Not convincing, to be honest. I personally never use it as a preventative, but not infrequently. I see patients who come to me on pregabalin and they say, well, it works. And I say, well, okay, if it works, you can keep going and you can even increase the dose. So sorry, Dr. Yos asked another question. How high dose are we talking about for prednisolone? So the trial, we're talking about 100 milligrams daily of prednisolone for 5 days, and then decreasing it by 20 milligrams every 3 days. So 100 milligrams for 5 days, then 80 for 3, 60 for 3, 40 for 3, 20 for 3, and then stop. So that's what we're talking about. And the dose of inhaled sumatriptan, basically you give them one inhaled, which is 6 milligrams from memory. So you try it with one inhalation first. The next time it doesn't work, you can try them with 2. Okay, you're welcome. All right. Yeah. One day I will figure out how to use this. One of my friends was saying you always found it very amusing that you go for a presentation and you have all these professors of medicine and whatnot struggling to use the computers. And, unfortunately, I'm not a professor of medicine and I still struggle to use a computer. But anyway, here you go. So This is sort of a bit of a discussion time, and I guess it's a bit tricky to discuss this over a web forum. If I unmute everybody will just sort of talk over each other. It'll be very noisy. Apparently, there's some other Zoom package that we can actually break people into groups of 4 or 5. But I'd just like you to reflect on, or you can put in the chat if you like, your most recent headache patient. Think about how you came to a formulation of what the headache subtype is or was. So you know, I think one of the things that I was taught in medical school and as a junior doctor, that we should always have a working diagnosis, whether right or wrong. It's important to have a working diagnosis, because that way you have a path forward, whether you have more test or therapy to help strengthen or refute your diagnosis. But if you have no working diagnosis, then you're out on a limb, really. I mean, we're just like the patients. Why have they come to you as a medical practitioner? It's for you to apply your skills and your knowledge to help them, and we can't do that if we're just sort of being very imprecise. I mean, you might be wrong, but that's fine. You know, you don't be too sort of concrete about it. But if you are a bit waffly, then you know it's not very helpful. Sometimes that happens because the patient doesn't fit neatly into one box or the other. But then that's why you have, you know, your working differential is this, and then your other differentials are that, right? So I like to have a think about how many appointments or how long do you need to see a patient to come to a diagnosis of a headache subtype. And I know that in GP land, you know, sort of time is money, and the MBS rebate is criminally low for GPs. I take 40 to 60 minutes for new appointments, and I get paid quite a lot by Medicare for that. And then I get a big gap on top of that. So most GPs don't have that luxury, so you might need to bring the patient back on a few occasions to come up with a formulation. All right, because you might take the history and then say, well, okay, time's up. Come back for another outpatient, and I'll do the examination and then write the assessment, and then you bring them back again for the therapy part. Explain to them what the headache is, what the acute treatment, what the preventative treatment, and then you know your 10 or 15 minutes is probably up. You have to bring them back again. So you know, you have to think about the financial and Medicare considerations for this. I mean, are you going to bill them at 23 or 36 or 44? And you know, probably should charge them a gap payment. And you shouldn't be shy about trying to get payment, because good medicine takes time. I mean, I often bring this up with my patients. You know, that they have a pretty straightforward migraine, and I put them on one first-line therapy like verapamil or propranolol, build up to 14 BD, not even that higher dose, and they're headache-free, and they've traveled several hundred kilometers from the country to come and see me, and they pay $100 gap or $170 gap. And I said, well, you know, why didn't you see your GP for this? You know, it will save the taxpayer about $100, and it will save you about $50 out of pocket. And you know, they say, oh, you know, I don't want to pay the GP a gap, and then that's what they end up. They end up paying a lot more money out of pocket and to the taxpayer, or they get sent to a public hospital and they wait a long time. So these are some of the considerations. I mean, you know, I probably should tell these to the patients, which I do, but by the time I tell it to them, it's too late because they're already seeing me. So don't shortchange yourself. I think most of the time, most of these, none of these drugs are that special. We talk about things like botulinum toxin. There are PBS and MBS rules about who can prescribe it, which personally I think are ridiculous, but that's how the government uses it to constrain cost. And the CGRP antagonists, I can enroll patients in a PAFP or free trials, which GPs don't have access to, unfortunately. But beyond that, all the drugs you can prescribe. So have a think about these questions. What's the most common headache complaint you see? And reflect on how do you deal with diagnostic uncertainty. I probably don't need to tell you that, because GPs are generally much better at that than sort of partialists are. We often try to pinpoint what the specific diagnosis is, and then, you know, especially neurology, we feel very clever, and then there's not anything we can do about some unfortunate genetic mutation. But there you go. We can write up the patient and publish it. So, sorry, maybe slightly facetious, but have a think about this. I don't know whether people want to type in the chat box, or should we sort of move on? We sort of are running ahead of schedule. If patient has a headache, they expect a treatment on that consult. You believe they were unhappy with the consult was spread over 3 consults. Well, I mean, well, that's true, but then you need to manage expectations. You know, you say, well, I want to make sure that we're having the right thing, and you know, perhaps you can book a ultra long 40-minute appointment the next time, and then we'll go over it, and I'll start you on treatment. And you can pay a gap, because Medicare gives $130 or whatever it is for 44, which is, you know, not really that much, really, considering that if they come to me and I bill them a 132, the Medicare give me $230. So, you know, and then I charge them a $170 gap if they don't have a discount, a pension card, and a $100 gap if they do have one. So, you know, that's kind of the price that they pay. I mean, you know, you can pick cheap, fast, and good. You can pick 2 of the 3. So that's unfortunately what you want, or what it comes down to. Is that a fair comment? Yeah. So yeah. So I agree. I think, you know, the treatments. I mean, really, even Botox. I personally think that, okay, if you want to really cost constrain it, ask the patient, ask the neurologist to start the treatment, but then ongoing treatment is subcut injections. You know, it is very simple, and you know, the patients want the problem is that the Botox vials, $450 plus GST from Allergan or AbbVie as it is now, and it's not, and you need 2 vials for migraine because it's 155 units. I suppose you can keep the extra 45 units for some cosmetic injections and recoup your money that way. But you see, the patient probably not happy to pay $1,000 every 3 months for the medications. But of course, they get it from us, then it's paid for by the PBS. All right. Now, so we'll move on to treatment options, a bit sort of in a bit more formal fashion, unless anyone has got any final thoughts. So with regard to treatment, some of it seems fairly straightforward. Lifestyle measures. So if they can identify a trigger through an activity diary or diet or food diary, then they should avoid them, obviously. A patient with aura, I usually use it as an opportunity to tell them that this increases the risk of stroke. So it's a sort of nice segue into think about motivational interviewing for quitting smoking or avoiding vasoconstrictors like amphetamines or their ice or their cocaine or whatever, or to quit smoking because they're already slightly high risk of stroke. So they should stop their cigarette smoking, or they should have safe alcohol use. They should have regular sleep because having too much or too little can trigger their headache or migraines. They have regular meal times to regulate blood levels, and also the type of food, so-called anti-inflammatory diet. It's sort of been hard to design a trial for, not least because there's no money in it, unless you're Pete Evans or some celebrity chef. But you know, if you've got a Mediterranean style diet, so high in vegetables and unrefined carbs, low in red meat. Yes, so Dr. Yo is mentioning about COCP. It's a relative contraindication. But so, you know, I believe that LARCs are probably safe. Progesterone only contraceptives or long-acting erectile contraceptives is probably safe. And the other thing to bear in mind is that most of the migraine preventatives are a category C or X in pregnancy. The sort of safest one is pizotifen, which is not that effective. It's a category B1, not that effective. It can help for some people. It's also notorious for causing weight gain. All right, so the next thing from Dan Dorpan is, what's the current thinking of caffeine as a migraine treatment? Yes, it probably works as an acute treatment. If you combine caffeine, it's in addition to paracetamol or NSAID, it can be helpful. The problem is that it can also cause medication overuse. So if someone drinks a lot of caffeine, that sometimes asking to stop the caffeine for a month and then having 2 caffeine days a week as if it were one of those analgesics that cause analgesic overuse headache, that can reduce their daily headaches. But in terms of aborting an acute migraine attack, yes, caffeine is probably effective, with all the caveats that it can cause medication overuse if you overuse it. So a keto diet has been shown to be effective in reducing migraine frequency. Hard to stick to, of course, and regular exercise can also be helpful. So if a person only has low frequency episodic attacks, you can consider just an acute treatment strategy. So give them high dose NSAID. Which one, anyone will do, but they all more or less have the same side effects. If the patients are concerned about clotting, then I'll go aspirin, 900 to 1200 milligrams. I used to suggest maybe consider the 500 milligram ones, but the 900 milligram aspirin is a lot more expensive than the 300. So you just often take 3 or 4 of the 300s. Together with paracetamol, together with triptans. And if one triptan doesn't work, then you should try. There are 5 available in Australia. There's sumatriptan, elatriptan, razatriptan, naratriptan, and zolmitriptan. If one doesn't work, try the others, because it doesn't predict class failure. They can be idiosyncratic. Or if one causes undue side effects, someone gets sort of very spaced out or drowsy on one triptan, you can try a different one. And the way I usually try it is, I would go high dose NSAID and paracetamol combination for their first attack. If that doesn't work, the next time they have an attack, they have that with the paracetamol, with a dopamine blocker, and a triptan. The triptan, I will start at a lower dose. So say sumatriptan, I give them 50 milligrams for the first attack. And if that doesn't work, the next time they'll go for 100. We add a dopamine blocker not because we are trying to treat their nausea. As people might know, dopamine blockers are not that effective anti-nausea drugs. But what the prochlorperazine or metoclopramide or the domperidone does is that it speeds up gastric emptying, so that the triptan, the NSAID, and the paracetamol are more quickly absorbed, number 1. Number 2, dopamine 2 receptor activation is implicated in migraine pathogenesis in models, in experimental models. So with some direct D2 blockade, that has some direct anti-migraine effect independent of the speed of absorption of the other drugs. So that's the second reason we give it. And then the third sort of rather tangential reason is that yes, it can help with nausea, but even if the patient has no nausea with their migraine attacks, a dopamine blocker is still indicated and helpful. Now, if you're concerned about causing drug-induced Parkinsonism, domperidone doesn't cross the blood-brain barrier and doesn't have that risk. And if they don't tolerate one, they had an oculogyric crisis previously with prochlorperazine, you might be able to get with metoclopramide, but if you're not game to try that, you can probably get away with domperidone for the reason it doesn't cross the blood-brain barrier. Hence, possibly slightly less effective. It still does the gastric emptying part, which probably goes with the brand name of Motilium. But it might not be that effective in the central blockade, although in the area postrema cumulative trigger zone, maybe that is still activated in migraine models. So it's still worth trying. So we got to the caffeine bit, which Dan asked about earlier. You can add caffeine in, either in the form of a combination paracetamol caffeine tablet, or you can give them a no dose, or they can drink their aspirin paracetamol with a strong coffee. So espresso is about 70 milligrams of caffeine, and an instant coffee about 150, depending on how generous your scoop is. So you're sort of looking at 100 to 200 milligrams of caffeine instead. A no-dose tablet is 100 milligrams. So if you read up to date, they talk about the G-PANTs, which is an oral small molecule CGRP antagonist, and the DITANs, the exact mechanism which I cannot remember off the top of my head because it's not available here. But they might come soon because, you know, Australia is a rich country and it's quite a lucrative market for pharma companies. So those are small molecule inhibitors, specific anti-migraine therapy. And of course, the good old ergots, like dihydroergotamine, can cause pulmonary fibrosis and valvular fibrosis, and also a vasoconstrictor. But they work, and you can get it through a compounding chemist. And they can be given PR as well, if necessary. So can indomethacin suppository, I suppose. But anyway, a big thing to do is to avoid opioids. Please avoid opioids. I cannot stress that enough. If your patient can't, you know, is on opioids for cancer pain, I suppose that's a different story. And if they need it for very significant musculoskeletal pain to function, then, well, I mean, I'll have to cope. But if you had to pick opioids, don't give them codeine, because codeine is not really that strong an opioid anyway, and it is quite notorious for potentiating the central pain sensitization. Oxycodone or morphine are better than codeine in that regard. A lot of patients complain of neck stiffness or muscle tightness with the headache. That it probably just reflects overactivation of trigeminal cervical complex with referred pain in those areas. So please don't try and give them benzodiazepine as a muscle relaxant for various reasons. It's not least because it doesn't really work to help abort the headache. They make people less anxious, and of course, pain has a strong affective component to it. And so the benzodiazepine is probably treating the anxiety, and so they feel better subjectively. But you run the risk of making people dependent on benzos. You can consider giving people nerve blocks to greater occipital nerve, supraorbital and supratrochlear nerve as a temporizing measure, especially if you're trying to get them off medication overuse, and the headaches do get worse for a week or two once they stop all the analgesics, but they start to get better. So sometimes you can give them methylpred, 40-50 milligrams as your preference, mixed in with either lignocaine or bupivacaine. There is a Medicare number for this. It's not super lucrative, but I don't think it's restricted. I think GPs can access that Medicare number. I think it's only $30-something for the GON and $40-something for the supraorbital nerve. So try and inject it on the side that they have it. The methylpred there is a PBS item for methylpred, 40 milligrams, and same for lignocaine. Bupivacaine is not on the PBS, but it's not too expensive. And you just need to be cautious about injecting steroids. So greater occipital nerve is fine to inject both because, you know, if people get lipoatrophy under the hairline, they don't really care. But if they get lipoatrophy and get a little divot above their eyebrow, it's very obvious, and people might complain about this cosmetically. So just something to bear in mind. So often people will actually avoid steroids in the supraorbital and supratrochlear nerve region. I've got a patient that I inject who has lipoatrophy, and he's happy to keep going because he says he only gets 2 or 3 days relief with the bupivacaine, so 2 or 3 weeks relief with the steroids involved. But it's just something to be cautious of legally. So how do you do it? That's the, you know, I mean, I was never sort of formally taught before I started doing it, and then I sort of Googled and found a YouTube video and a few articles saying where to inject. But basically, where this needle is, the greater occipital, I never bother injecting the lesser occipital nerve. So what I do is I drop about 50 milligrams. So I dilute a 500 milligram vial of IV methylprednisolone with 5 mils of, with 5 mils of water. So I have 100 mg per ml, then I drop 0.5 mils of that solution, which is 50 milligrams, and then I drop the remainder in the 3 ml syringe, 2.5 mils of bupivacaine, 0.5%, which I get through the hospital pharmacy. But if you want, you can drop with lidocaine 1 or 2%. Doesn't really matter. And then I inject sort of vertically 1 mil, and then I angle it and inject 1 mil to the left and then angle it 1 mil to the right. So that's what I do for the greater occipital nerve. And the supratrochlear nerve and the supraorbital nerve, I would inject them for my patient who I give steroids. I'll do the same, and he ends up with a little egg on top of his head. If you're just injecting local anesthetic, probably 2 mils enough. What are my thoughts about upcoming downscheduling of sumatriptan? I have to say, I was not aware it's going to be downscheduled. Would you care to elaborate on what the downscheduling is? Are they trying to let pharmacists prescribe it, or what's the story? Over the counter. I don't think it's a great idea. I think you're just asking for medication overuse. But you know, the pharmacist will argue, oh well, you can get medication overuse with paracetamol. So no, I mean, personally, I don't think that is a great idea. But unfortunately, that's life. I mean, the only advantage I can see for that is that, they will come to you and they said, well, I tried sumatriptan with ibuprofen and aspirin, it doesn't work. And then you can say, well, let's try something else. But no, I personally think that's not a great idea, but there you go. Well, I've got nothing to add beyond educating the patient that they do have medication overuse. I mean, it's just the same as if they take too much paracetamol. I mean, one of the useful strategies to help tell the patient, you ask them, so what do you do when you have your headache? And they say, oh, I take Panadol and I take Imigran, and I say, okay, and then what does it do? And they say, well, it doesn't really do anything. And I say, well, okay, then why do you keep taking it? And they're like, oh, I feel like I have to do something. So you say, well, okay, we have to try to do something, but let's do something that works. And one of the things that works is to stop these drugs for a month, and thereafter having no more than 2 days a week. So that's what you tell them, I guess. Unfortunately, behavior change is hard. I mean, you are all better at it than I am, I'm sure. But we just plod along, and sometimes some people are beyond helping. Some people just can't be helped, and if they come and they say, well, I know you suggested that I should take this drug, but my homeopath suggested that I should take ground up something or other, and I said, well, stop coming to see me and keep seeing your homeopath. So that's just reality. I mean, if they don't want to be helped, they can't be helped. Anyway, all right. So, oops. All right. So we'll move to the next slide. Here you go. So just for me going over the various preventatives, the antihypertensives. Can be used. I quite like them because they're generally quite benign. Verapamil. Oops, sorry. Go back up. I'll just move up one slide. There you go. Verapamil is very well tolerated. I usually start people on the immediate release one for migraine because that's where the evidence is. It is a bit of a pain, but the habit breakfast, lunch, and dinner is not too bad. I started 40 TDS for a week. If they don't have any problems, i.e., they do not become bradycardic or pre-syncopal or syncopal, then I say up it to 80 TDS. If they're partial but incomplete benefit at 80 TDS after a month, I would up it again to 120 TDS. For clusters, so use a controlled release preparation. But so verapamil is quite well tolerated. The caveat is that it does inhibit P glycoprotein. So it does put up the concentration of certain drugs that are metabolized by PGP. For example, the dabigatran, direct oral anticoagulant. So you need to watch out for the bleeding or switch them to a different anticoagulant. And they cannot have grapefruit juice and probably other citrus. I mean, sweet oranges are probably fine, but other citrus fruits like grapefruit, but also things like pomelos and some of the more unusual limes like Macrut limes and some more exotic lemon type things can inhibit the metabolism of verapamil, and it can make the concentration very, very high indeed, and it can give you a heart block. So you just need to be mindful of that. So the best avoid citrus. You can have sweet oranges, but not marmalade. Because the bitter oranges are significant, and it so surprised me the number of different citruses there are. There's only 3 primary citruses, and then the rest are all hybrids. So you can never quite tell what's what. So I want to be quite cautious with sweet oranges are probably fine. A squeeze of lime or lemon juice on their food is probably fine, but not beyond that. So that's the only problem with verapamil. I mean, and the fact doesn't work that well, probably. It's not super effective. I mean, maybe 40% to 50% of people have some appreciable benefit with it. But it's quite benign, so it's nice to try. Beta blockers limits heart rate. Sorry, I'll just answer Dr. Yo's question here. Muscle spasm in the neck. Could you talk about cervicogenic migraine? This is misnomer. Is it the migraine causing neck pain? Yes, correct. It is the migraine causing a neck pain. And bitter orange is the same as a Seville orange, but blood oranges can go either way. Blood orange is you have a sweet blood orange, it's red, but it tastes sweet. That's still considered a sweet orange. But I believe there are bitter blood oranges as well. So the sort of Angostura type, the sort of Italian style red blood oranges, and that probably is not. Now, there's a phenomenon called cervicogenic headache, which is probably overdiagnosed and more common, but it is what Dr. Yo says. There's this phenomenon where people's sort of neck gets quite stiff, and then they get a headache, or they perceive that the pain starts at the base of the neck, and then it spreads anteriorly and then down the neck. So it's a bit hard to say. Most of the time, this is actually a migraine which just manifests in the neck and then spreads to the head. There is a small subset, of course, of people where the neck spasm triggers the migraine because the brain is already primed. There's sort of well-established pain network. So any sort of stimulus to the cranial-cervical region precipitates a headache. And so these are the patients who improve with physiotherapy, for example. And that's potentially worth trying. There are a few people with true cervicogenic headache, and that's normally the way to prove that is to block the nerves in the cervical region with regional nerve blocks to the facet joints. And if the headache goes away, then you say you've got cervicogenic headache. Now that seems a rather invasive way to me to do things. So pragmatically, what I do, and I know the GP is probably going to roll their eyes because this is a classic, subspecialist over investigating things. But I do a nuclear. If the patient is so adamant or has a story quite suggestive of cervicogenic headache, i.e., they move their head and then boom, it triggers the headache, then I do a nuclear medicine uptake scan of the neck and the base of skull. If there is increased tracer uptake in the facet joints or the or around the nerve roots, which indicates sort of low level ongoing inflammation, then I'm inclined to say, okay, let's then get a radiologically guided steroid and local anesthetic block of those increased uptake areas. And that way, your invasive procedures are a bit more targeted, and you get a slightly better hit rate than just saying, well, it looks like a bad OA of your neck on the plain CT or on the X-ray. Let's go and block it. Well, I mean, personally, I don't like doing that. I think that's a bit imprecise. If they've got increased tracer uptake, sure. Especially if it's very side locked and that's the side that is all lit up, then I would be inclined to go for neck block. And then I would say, well, actually, they do have a spicogenic headache. What do you know? But, that's, there you go. Okay. Now, someone's asked another question saying, why do triptans have to be avoided in brainstem aura? It is a theoretical concern that triptans, by way of mechanism of action, they block serotonin, the 5-HT3 antagonists, and when you block serotonin experimentally, that sort of causes vasoconstriction, or at least doesn't allow for vasodilatation. So you're concerned, hypothetically, that you might cause vasospasm, which is why there's a caution for people with ischemic heart disease or cerebral vascular disease that you might trigger a migraine. Your risk of triggering a migraine is something in order of 1 in 1,000, 1 to 3 in 1,000. So 1 in 1,000, 1 in 100 chance, 1 in 300 chance, I should say, of causing a stroke with triptan. If in brainstem aura, we believe that from functional MRI studies or SPECT studies, for example, that there's decreased blood flow causing corticosplenic depression, and we cause further vasoconstriction, then they might get a stroke, and if they get a stroke in the brainstem, it can be bad news. It is a more theoretical than, I don't, not to my knowledge that has there ever been someone who had a brainstem aura or a triptan and then had a stroke from that, attributed to that triptan. But I guess, as doctors, we are somewhat understandably a bit risk averse. And so we try not to do that, I guess. I mean, it's very debilitating. Then, you consent the patient and you document well that I discussed the risk of stroke with this, and the patient is happy to proceed on the basis that the migraines are so debilitating, so we try the triptan. Okay, so that's number. The second question was, please advise optimal time in migraine evolution to give triptan. That is a good question, and I don't really have a great answer for you. I think if you know if the aura is very predictable and it's always 15 minutes, there's some argument that you can try giving it at the start of the aura. But if our aura is of variable times, and sometimes it's 15 minutes, sometimes it's 60 minutes, then maybe you should start giving it as a headache. It's just starting, because kind of you want to have the peak dose just around the time when the headache is sort of evolving. So often the conventional teaching is to give it just as the headache is starting. But I guess that it does give some room for trial and error with your patient. Well, why don't you try it at the start of the aura, or at the start of headache, and see which one works better. That's it. I hope that answers the question. Okay, so beta blockers, yes, they work. 1 in 300 chance of causing diabetes from your beta blocker in someone who otherwise wouldn't get it. And it can cause depression, can cause slight sexual dysfunction, and limits exercise tolerance, and can cause bronchoconstriction. But you can choose. If you've got some other indication for a beta blocker like ischemic heart disease or AF, then that's a fairly straightforward thing to choose. Don't generally use it in combination with verapamil. Anticonvulsants, valproate can be quite effective. Normally start 200 BD, go up to 400 BD. There are some case reports you need to push up quite high, but I think if they've got no benefit at 400 BD, it's probably not going to work. I wouldn't give it in women of childbearing potential. And it can cause weight gain, especially in people who are already slightly overweight. The propensity, people are sort of not overweight or don't have a tendency to become overweight, then valproate often doesn't cause weight gain. But if someone's already slightly overweight, then often they do put on quite significant amounts of weight on valproate. So you need to be cautious about that. Topiramate, good drug, is actually on the PBS, albeit annoyingly at the sort of 25 milligram tablets only. So I'll start at 25 Noctare, increase it to 25 BD in a week, then 50 BD in a week if they tolerate it. And if they got some but incomplete benefit at 50 BD after a month, I would push it up to 100 BD. 1 in 4 people, especially the higher doses, can get depressed, and it does cause cognitive slowing, especially and it is dose dependent. So, you know, some people might say, well, my headaches are a lot better at 75 BD, but I can't find the right words. And that's often what they complain about, word finding difficulty. In which case you might drop it to 50 BD and see if that's tolerable. You know, you might lose some benefit with migraine prophylaxis, but they can still work, you know, as a lawyer, for example, because they need to find a bond more as a lawyer to impress the judge, and they don't want to have any cognitive slowing. So that's where the topiramate fits in. It does also cause paresthesia, does increase the renal calculi and angle closure glaucoma. So you need to say, make sure you have at least 2 or 3 liters of water a day. You need to monitor their bicarb, you know, at baseline, and then every 3 to 6 months check that their bicarb is still all right and their other biochemistry hasn't gone off. Lamotrigine, as I mentioned earlier, mainly treats the aura, doesn't really do much for the headache. But if aura is very bothersome, that can be quite helpful. It's not on the PBS for the indication. And topiramate, if you want to give them 50 milligrams, it's not on the PBS either. So it's a private script. But neither of those drugs are that expensive. Topiramate is category D in pregnancy. Higher doses are worse. Valproate is known as category X. Lamotrigine is actually category A, I think, or at least B1. Lamotrigine is quite safe in pregnancy, but anyway, there you go. But people's migraine often improves in pregnancy anyway. The problem, of course, 50% of pregnancies are unplanned, and your valproate and topiramate will always be on board when they fall pregnant, which is the worst time for it to be. Likewise, ARBs, beta blockers, verapamil, all category C in pregnancy. Amitriptyline, also category C in pregnancy. How do I start it? I start it. So I should tell you about dosing. Beta blockers, I usually give them 40 milligram tablets. Okay, so I might get to Jackie's question just in a moment. So beta blocker, I give propranolol 40 milligram tablets. I say half a tablet twice a day and increase by half a tablet every week or so until you hit 80 BD. And if that works, it's going to work. If it doesn't work, it's not going to work. And you know, try at least for a month, and then if there's no benefit, wean off. Lamotrigine, the main risk is rash. That's probably the main side effect, severe rash. So if I mean, they probably won't be taking valproate. If they are taking valproate, I'll start for whatever reason, whether they have epilepsy or bipolar affective disorder. I will start lamotrigine at 25 milligrams alternate day. So 25 milligrams every other night for 2 weeks, then 25 milligrams every night for 2 weeks, then 50 milligrams every night for 2 weeks, and then 50 milligrams BD, and then maybe up to 100 milligrams BD if necessary. Because if you do it slowly like that, your risk of rash is a lot lower. If you're not on valproate, just start at 25 every other night. 25 milligrams every night for 2 weeks, then 50 Noctare for 2 weeks, then 50 BD, and then 100 BD thereafter. So it's a slow titration. If they are on a CYP3A4 inducer like carbamazepine for trigeminal neuralgia or for epilepsy, then I'll start at a higher dose. I'll start at 50 milligrams once a day, and then increase it every 2 weeks. But bearing in mind that that's a sodium channel blocker, and you add it to carbamazepine, you run the risk of making it ataxic, which is reversible if you stop it. But that's just something to keep in mind. All right, so amitriptyline, I give them 12.5 milligram tablets. This is very helpful if people have sleep onset insomnia, they ruminate, or they can't switch their mind off, and they just lie in bed for a long time. You start them on amitriptyline 12.5 Noctare, give them 25 milligram tablets. Every 2 to 3 weeks, go up by 12.5 milligrams as tolerated, up to 75 milligrams. If they if they have benefit at 75, that there's no convincing evidence that there's much benefit to be gained beyond 75 milligrams for migraine. For tension type headache, yes, you can push it up to 125. But if they have some benefit but incomplete with migraine at 75, maybe you can try upping it to up to 125. But I would still go in 12.5 milligram increment. The other thing, but if they're not any better at 125 versus 75, then I would drop them. Just remember to drop them back down. Go up to the dose that you think is going to help. And after a month, you should review it and then de-escalate the drug. And likewise, if they go up to 75 on amitriptyline, after a month, their headaches are the same, I would stop it. I would wean it off and drop it by 25 milligrams every week until they're off. If they have a bit of anxiety or insomnia after coming from 25 to 0, I'd say, well, go on 12.5 milligrams for a week and then 12.5 milligrams alternate night for a week and then stop. And then warn them that you might feel a bit edgy, for 2, 3, 4 days after you stop, and then you should pass. Sometimes amitriptyline causes unacceptable drowsiness in the next morning, and if that doesn't go away after 2 or 3 weeks, you can switch them to nortriptyline. Not on the PBS for migraine. Nortriptyline is only for depression, but it's pretty cheap. It's sort of $10 for 50 from Chemist Warehouse as a private script. If they have depression, then there's not a problem. You can prescribe it happily, and then you won't get in trouble with the PBS. Although nobody from the PBS is going to come and chase after you for a $10 a month drug. So you probably, people can get away with it, I think. Pizotifen, sorry, I've misspelled it. It can cause weight gain. You need to give enough. So normally I start at, half a milligram, but I escalate it every 3 or 5 days by half a milligram to at least 1.5 milligrams at night. Sometimes, and then I'll push it all the way to 3 milligrams if they don't have any side effects. If they have no benefit at 3 milligrams at night for a month, I stop. If they have partial, I push it up further up to 4.5 milligrams. So contraception is important. Just make sure you discuss it and you document it. So this is the PBS criteria for Botox. There's a specific protocol, inject 31 areas around the head and neck every 3 months. If they have pain that's more side locked on one area, you might give a bit more, so you can give up to 200 units or 195 units per time. Unfortunately, GPs can't give it. The CGRP calcitonin gene-related peptide antagonist, there are actually 4, but there are 3 available at the moment. The 3 that are currently available are all subcut. There's erenumab, the brand name Aimovig, if I'm allowed to use brand name in this talk. That is a CGRP receptor blocker. The other 2, galcanezumab, brand name is Emgality. That one is still available at the moment as a free trial from the company. I think it's Teva who supplies it. We can give them a loading dose of 240 milligrams for the first month and 120 milligrams monthly thereafter. That's the dosing. The company will give the first 3 injections free, which is 2 months worth. Thereafter, the drug is $297 plus dispensing fee. The pharmacy charges it, so $300 a month. So it's not cheap. That's a CGRP ligand monoclonal antibody, so it binds to the peptide itself and takes it out of circulation. The other one is fremanezumab. The brand name is Ajovy. That one had a patient familiarization program, but it was so popular that it got fully subscribed, and so the company stopped supplying because they were going to go bust. I don't know how much that's going to cost, but it's around the area. Erenumab, the company Novartis has taken it out of consideration for PBS listing, so it will never be on the PBS. And that costs about $400 an injection, might come down a little bit. Having 2 injections is a bit more effective than having 1, but that means you're looking at $800 a month rather than $400 a month. Patients can get a little bit back if they have private health with extras cover, but normally there are limits. I think it's about $600 a month, so it uses up pretty quickly. Now, if your patient would like to have a non-pharmacological but evidence-based treatment as a preventative, these are the things that have some evidence that's come from this paper in Nature's Review Neurology, which is quite an interesting paper to read because it sort of hypothesizes that migraine is an adaptive function of mitochondrial energy demands being not met. And so the mitochondria throw a hissy fit, give you a migraine, and you sort of lie still until your ADP levels have sort of diminished and you are able to move around again. So things like, so these are all not in combination, but you can either try riboflavin 400 milligrams a day, or coenzyme Q10 400 milligrams in capsule form or 300 milligrams in liquid suspension form. Not sure why there's a difference, but there you go. Alpha lipoic acid 600 milligrams a day, or a combination of folate 2 milligrams plus pyridoxine 25 milligrams with vitamin B6, or and vitamin B12 400 micrograms. So to be swallowing a handful of B vitamins every day, or magnesium oxide 500 milligrams a day. So that's another option. So those all could work, and some patients are happy to try these and not happy to try the pharmacological things. So that's something to consider. Okay, so sorry, I'm sort of mindful waffling on a bit. Canotype headache, you treat with education. Tell them why they're having it. You know, wander on holiday and thereafter make 2 days a week. Try not to be the cause of people's headaches, because you know we prescribe these things. I mean, paracetamol they can prescribe themselves, but we often prescribe opioids and triptans. We give them the acute treatment. Triptans are only really helpful if they have migraine. Doesn't really work for pure tension type. And tricyclic antidepressants, as I mentioned earlier. Topiramate, possibly helpful. It's not on the PBS for this indication. Tizanidine is a muscle relaxant. It's a bit of a kerfuffle, but we can import it through a special access scheme B, usually apply to the PBAC, and it winds up about $50 to $100 a month. So I don't know. I've got one patient on it. I don't know how effective it is yet, because they've just got the drug. So, you know, I'll keep you posted. And once again, please avoid opioids. So cluster headache, acute treatment, I've talked about earlier. Verapamil, this is probably more for the chronic ones that you need to keep pushing. For the episodic ones, you just sort of start on the day they have the attack, because no point being on medication, you know, for continuously if you get one to take every 3 or 4 years. You can push it up to 480 milligrams. You should do ECGs before and after each time you increase the dose. You probably don't really need to worry about lithium, because really if they're needing lithium, they probably would end up seeing a neurologist, but you could do it if you're game. You need to monitor the levels, because lithium is quite toxic. It can cause a tremor, it can cause diabetes insipidus, probably nephrogenic diabetes insipidus. Galcanezumab is not a PBS4 cluster. It's got some evidence, not in the migraine doses, but so don't worry about that too much. And topiramate, again, some evidence, but again, not something that you would try. Something that people like me would try in desperation if nothing else is helping. Okay, so probably sort of getting on in time. So I guess this is just for you to reflect. How would you approach your next migraine patient? Think about the comorbidities, their hypertension, their insomnia, etc. How would you try and persuade people to come off their analgesics? Or they're sort of asking you, oh, doctor so-and-so has always given me pethidine injection or fentanyl or whatever. That's the only thing that works. How do you try and, you know, if you prepare and rehearse beforehand, you're more likely to come up with a coherent, convincing answer that the patient doesn't feel they're fobbing them off. And the counseling of the patient and medication overuse. Okay, so just briefly, perhaps I should have started this in the beginning, because there's a primacy and recency effect. So I'm relying on the recency effect here. The last thing you hear before you go off tonight. Red flags, if they get a new onset headache, never had headache before in their life, and then suddenly they are 50 or 60 and suddenly get new headache, that's concerning. If your examination reveals something abnormal, if the headache is thunderclap in onset, i.e. reaches peak intensity within a few minutes. So, I mean, this is a bit arbitrary, but 5 minutes, I would say, if it comes to maximum intensity. Or they get papilledema, which sort of implies there's some sort of pressure within the cranium. So if they have red flags, they should warrant neuroimaging, And if you can organize an MRI, please organize an MRI. I find CTs, the only thing CT is really helpful for is to exclude acute blood. The reason why I say this is because if your CT is normal and you suspect someone has something dodgy, you get an MRI. If your CT is abnormal, you get an MRI. So why not save the taxpayer $150 and save your patient a bunch of radiation and just go for the MRI? All right. So the so-called trigeminal autonomic capillalgias, cluster headache we talked about, paroxysmal hemicrania is very side-locked. They're very autonomic features. It's very severe, not as bad as cluster, but pretty bad. But nice to pick up because you can cure them, if you like, with indomethacin. Or, well, you don't cure them, but their symptoms go away completely or nearly completely, and they think you're, God's gift to medicine or something. Similarly, hemicrania continua. The pain is not usually as severe that they don't have superimposed pain episodes, but it's continuous, unremitting, very, very side-locked, and indomethacin responsive. If you pick it up, you'll feel very smart, and you can, pat yourself on the back and say what a brilliant doctor you are. Sanct and Suna are more short-lived, so they don't have acute treatment because they're too short-lived. They're literally a few seconds. And it could be confused with, for instance, trigeminal neuralgia. And the treatment for them is preventative treatment with lamotrigine. Unfortunately, not on the PBS for that. So it's unfortunately a private script, or if you're in a hospital, the hospital pays for it. Other things to just keep in mind, people can get low pressure headache. Often this occurs after epidural or lumbar puncture. They're worse when they're upright. There's a pulling sensation. Can occur spontaneously, especially people with connective tissue disease or this sort of hypermobile. They can get spontaneous leaks in the CSF. Of the CSF. You do an MRI with contrast and a linear enhancement, and you can see the brain sag in the midbrain. Can be quite significant. Sometimes they can accumulate because of hygroma or bleed, and the treatment for that is a blood patch. Cervicogenic headache we touched on earlier. Hypnic headache, so-called alarm clock headache, wakes patient from sleep same time every night. Quite rare. Treated with caffeine, believe it or not, just before they go to sleep. Have a couple of strong coffees. Nummular headache. Nummular comes from the sort of Latin word for coin, and it's a coin-shaped or size headache anywhere in the head. Again, a rare headache subtype, not that well studied. Treatment is a bit sort of anecdotal, empiric, with trial of indomethacin or trial of melatonin. Primary stabbing headache, one of those that if it migrates around, you probably are quite happy that it's not going to be some underlying structural lesion. Very severe, but very brief. It sort of makes the patient wince, but then goes away. And if it moves around, you're happy that, well, okay, it's not going to be a venous sinus thrombosis or a tumor or something, because, that's not going to migrate all over the head. And you can try them on melatonin or indomethacin or something like that. But look, all this is small print, and I think if you sort of send a referral to a neurologist saying, I wonder if they got this, the neurologist says, yes, you're right, you're very clever. Why are you sending the patient to us? And just in terms of resources, e-therapeutic guidelines is very good. So it's AMA telling you the doses and the precautions. Up to date, also very good. Unfortunately, all these require subscriptions, but I was sort of informed that this Health Pathway South Australia, I had a look at it. It's free. You have to register, but you get a generic logon, and it's very good. It's they basically said everything that they have to say, or I had to say today, and it's free resource. So I strongly encourage people to go and have a look at it. And so that's it really. And sorry, I sort of probably haven't left very much time for questions, but here we are, and I'm happy to take any sort of final questions if anyone wants to ask anything or make any comment. And if not, I thank you all for your attention, and we can have a good night. And yes, thank you. You're welcome. All right. So I think there's an evaluation for you to complete. It'll be much appreciated if you manage to do that, so that we can continue to get or SETMEA can continue to get funding for these events. Presuming they might want to choose a better neurologist next time, but anyway, that's sort of.
Dr. Zong, thank you so very much for presenting. We really appreciate it. I'm sure everybody took a lot of information home this evening. Very much appreciated. I'd also like to thank the Adelaide PHN for contributing to this very successful education session. I'd also like everybody just to stay on for another 2 minutes and complete a very important evaluation. This will pop up shortly, so just bear with us for the evaluation to pop up. And again, thank you everybody for your time this evening.
Thank you very much, everyone.
Thanks, Dr. Zong.
Have a good night.